Good day, I'm Raghav Sundar. I'm a consultant medical oncologist practicing at the National University Cancer Institute of Singapore. I'm also a translational clinician scientist, part of the Singapore Gastric Cancer Consortium. Along with Professor Patrick Tan and Professor Heike Grabsch, I would like to share with you the results of a genomic study of gastric cancer from a spatial perspective. Gastric cancer is the third highest cause of death worldwide. To date, chemotherapy remains the cornerstone of systemic therapy with few approved targeted therapy options. Several randomized phase 3 clinical trials of targeted therapies have failed in gastric cancer. Very often, a patient first presents with occult blood loss or abdominal pain and undergoes an endoscopy. During the endoscope, a tumor may be detected and several biopsies taken from the mucosal surface of the tumor. After discussion at a tumor board, if systemic therapy is the appropriate next step, the medical oncologist orders biomarker tests on the endoscopy biopsy specimen and treatment decisions are made based on these biomarker results. The deeper aspect of the tumor, which is not accessed by the endoscope, and the metastatic lymph nodes are not analyzed in this entire process. We hypothesized that the genomic heterogeneity in the different spatial regions may explain some of the discordant clinical outcomes. First, how similar or different are the superficial regions of the tumor to the deeper regions of the tumor of the same patient? Second, how do the superficial and deep molecular profiles of this tumor relate to the matched metastatic lymph node? This study included a cohort of 64 patients diagnosed with gastric adenocarcinoma who underwent potentially curative surgery at the Leeds Teaching Hospital. Multiple subregions were manually delineated in the primary tumor. First, two adjacent luminal subregions extending up to 2 mm deep into the mucosa were identified as superficial subregions. This is approximately equivalent to the depth that is reached by endoscopic biopsy. The median size of the individual superficial region was 35 mm square, which is equivalent to the amount of tissue that can be obtained from approximately 8 endoscopic biopsies. Next, one deep tumor subregion extending from 2 mm depth to the deepest point of the tumor infiltration in the wall was identified. Lastly, tumor was also outlined in the metastatic lymph node. DNA and RNA were extracted from each individual region. RNA was profiled using the nanostring pan-cancer progression panel, and DNA was sequenced using an NGS panel of 225 GI cancer-related genes and assayed using multiplex ligation dependent probe amplification for 16 genes. We performed a differential gene expression analysis between the subregions in a pairwise fashion. In these volcano plots, the wider and higher the V of the volcano, the larger the difference between subregions. First, we compared the two superficial subregions. We found no statistically significant difference between the two superficial subregions. We next compared the superficial subregion to the deep subregion of the tumor and found nearly half of the 770 genes measured in the nanostring panel to be different. The comparison between the metastatic lymph node and the superficial subregion revealed similar results. However, interestingly, a comparison between the metastatic lymph node and the deep region of the tumor showed much fewer differences. Findings from the DNA analysis supported the RNA nanostring analysis. Several therapeutically targetable genes were amplified, mutated, or overexpressed in the deep subregions and/or the lymph node metastases, but not the superficial subregions. When we go deeper in the gene analysis, we can see that the genes overexpressed in each subregion are different and linked to plausible biological programs and form different potential therapeutic targets. First, multiple superficial endoscopic biopsies of the tumor may not encompass the genetic heterogeneity as the gene expression profiles are actually quite similar. Second, it is very likely that the tumor is metastasizing from the deeper regions of the tumor as compared to the superficial or mucosal regions of the tumor. Future clinical trials of targeted therapy in gastric cancer must consider an assessment of the deeper subregions of the tumor and/or the metastatic regions. Our study also reveals some of the basic biological principles of metastatic dissemination in gastric cancer.